Good morning, everyone. And I love that we already have a little chat in the in the chat in the chat. But very, very excited about today's talk. And I believe this is the first time that Lizzy Hastie is presenting to us at High Rounds. I'm just going to tell everyone a little bit about her. Lizzy Hastie, her pronouns. She's originally from Cincinnati, Ohio, completed her undergraduate studies at the University of Colorado Boulder, and attended medical school at Emory. She moved to San Diego for internal medicine residency and stayed at UCSD to complete a chief year before starting her infectious diseases fellowship in 2022. She's in her second year of the fellowship and joined Sarah Gianella's lab this past summer. Her primary research project focuses on exploring and defining HIV reservoirs in the genital tract. She's also passionate about advancing research efforts in transgender care and medical education. And with that, I will turn it over to Dr. Lizzy Hastie. And Lizzy, I will keep an eye on the chat so you don't have to worry about it, although I feel like you're someone that often is looking at it too, but I got an eye on it. So
thank you so much. And you guys can hear me okay? Okay, awesome.
Excellent.
Well, thank you everybody for having me here today. I'm very excited to discuss the results of this research project, and I'll discuss this later, but I've kind of got to join on this project on the tail end, so I'm really grateful to have the opportunity. But the title of our project is Impact of Gender Affirming Hormone Therapy on HIV Reservoirs and HIV in Transgender Women. And this is essentially what we are presenting at CROI coming up soon. So I have no disclosures. For an outline, we're going to start with the background and rationale for this study. We'll go through the project methods, the results, and a little bit of a discussion, nothing too groundbreaking. My objectives, first one's a little long, but I think it's the most important. So the first objective is to evaluate and recognize the need for research on the impact of hormone therapy on HIV reservoirs and inflammation in transgender women. We'll also examine some prior research in this area and justify the hypothesis that we had for this study. And then, of course, we'll review the study methods and results. So to start with some background, I wanted to review some of the results of the 2019 to 2020 National HIV Behavioral Surveillance Report on HIV infection, risk prevention, and testing behaviors among transgender women. The paper notes that transgender women are reported to be disproportionately affected by HIV infection, which this is something I know we've discussed before, but in prior studies, it's been found to be up to 50 times the odds compared to the general population. But the motivation for the surveillance was the fact that there's not very much known about the epidemiology of HIV infection among this population in the United States. So to address this gap in our data, the CDC sought to implement this surveillance among transgender women. And they ultimately included 1,608 transgender women between 2019 and 2020, and it included 7 cities. So Atlanta, Los Angeles, New Orleans, New York City, Philadelphia, San Francisco, and Seattle. So a good range of cities across the country. And among the 1,608 transgender women, they found that 42% tested positive for HIV, and 78% of the participants with HIV were taking gender-affirming hormone therapy, and an additional 15% on top of that were interested in taking gender-affirming hormone therapy. So a really significant proportion of the individuals. They also discussed some of the benefits of gender-affirming hormone therapy that's been described in the literature. That includes that the access to gender-affirming hormone therapy may increase HIV treatment, that not being on gender-affirming hormone therapy is significantly associated with HIV treatment interruption, and that this is a double negative here, but essentially that gender-affirming hormone therapy decreased odds of not being on ART, or that taking gender-affirming hormone therapy, individuals who were taking this were more likely to be also taking their ART. So these all corroborate each other, but they were found in different studies, which I think is important to note, and was really a big motivation for this study question, research question. So knowing the significant positive impact of gender-affirming hormone therapy and HIV treatment, our study group came up with our primary research question, which was, how does the initiation of gender-affirming hormone therapy, and primarily in this case estradiol, impact HIV reservoirs, including size and activity, and inflammation? So this is our main question. And our hypothesis, which I think is really interesting, and I learned a lot about HIV dynamics, et cetera, because of this hypothesis question. Our hypothesis that there would actually be a decrease in cell-associated HIV RNA after starting estradiol. So to dive into our hypothesis and explain where it came from, it was driven in part by the results of this study published in 2018 by Das and al., including Dr. Jonathan Karn, who's the director of the Case Center for AIDS Research at Case Western. Their study was estrogen receptor 1 is a key regulator of HIV-1 latency that imparts gender-specific restrictions on latent reservoirs. And the essential findings of their study were that the estrogen receptor represses proviral reactivation of HIV and T cells, and that women were more responsive to estrogen than men. So they said that estradiol inhibits HIV transcription in a sex-specific way. And they also found that estrogen receptor antagonists, such as tamoxifen, partially reactivated latent HIV-1. So to highlight their findings a bit more, here's one of the figures in their paper summarizing their results and the findings, the primary findings that males and females respond differently to estrogen receptor agonists and antagonists. So just to highlight some things, so when they added estradiol, and this is adding to leukapheresis samples from men and women, they found that the estradiol, and this is in quotes because this is what they said in their paper, completely abolished the cell's response to C-cell receptor stimulation in women, also decreased the response in men, but to a smaller effect. And you can see that here where the red is females and the black is males, and females is completely abolished. And then they also found that when they added a combination of a T-cell receptor stimulator and then also an estrogen receptor antagonist, they found a greater induction of RNA positive cells in women compared to men. So this combination had resulted in more RNA positive cells in women than in men, just again, supporting the fact that males and females have different responses to estrogen receptor agonists and antagonists. So in conclusion, they stated that accounting for the impact of estrogen on HIV viral reservoirs will therefore be critical for devising curative therapies for women. And with our project, we are questioning whether this also includes transgender women who are on gender-affirming hormone therapy, primary estrogen. Okay, so with that, I hope that clarifies our hypothesis a little bit. So back to our project. I wanted to note that this project, again, was really started before I joined the lab. So here's the list of all the amazing co-authors who came up with the study and put in all the hard work. And again, I'm feel very lucky to be a part of this project at this stage. So starting with the methods for our study. So study participants included transgender women with HIV on antiretroviral therapy who were about to start gender-affirming hormone therapy. So this is a really unique population of individuals. And it allowed for testing prior to starting hormone therapy and then after. The study primarily occurred in San Diego, but there was also a subset of individuals recruited from a clinic in Houston. And the primary samples collected were blood, serum. And the goal was to collect samples at time 0, so before the individuals started hormone therapy, then at 2, 4, 6, 9, 12, and 18 months after starting hormone therapy. So this was to allow for a longitudinal evaluation of the impact of hormone therapy. We did have control data, which consisted of historical samples from cisgender men with HIV on ART. And the goal was to match these by age, CD4 T cell count, duration of HIV or time since diagnosis, and time on ART. So at each time point, the blood was tested for estradiol and testosterone by ELISA, cell-associated HIV RNA and DNA by droplet digital PCR. And then we also measured 41 cytokines or chemokines by Luminex. Additionally, at each visit, when they came to give blood, we also got some additional reported history from them. So we asked them which ART they were taking and how their compliance was, how adherent they were to it, which gender-affirming hormone therapy they were taking. This also includes if there was a change in any of their treatment and what they've taken in the past. And then we also got some information about alcohol and drug use at each visit. Okay, so the results of our study, we recruited 22 transgender women overall, and 77 samples were collected from the transgender women. And we had a control group of about 79 historical samples, which were reviewed. So main findings, so we found that transgender women had higher overall estradiol concentrations, which shouldn't be too much of a surprise, given that they were on estradiol supplementation. And this was 145 versus 45 with the significant p-value. And then the transgender women also had a lower testosterone concentration at 226 versus 436, again, statistically significant. And this was encouraging to us when we saw this because estrogen should suppress testosterone. And so this supported the fact that these individuals were taking their gender-affirming hormone therapy. And this was also supported by the fact that there was a sharp decrease after baseline. So the testosterone levels in transgender women dropped as expected once they started estrogen therapy. So HIV DNA levels, we found that transgender women had higher HIV DNA levels overall. This is in both total and 2-LTR. And we also found that both groups had a decline in 2-LTR, but there was a faster decline in transgender women after starting gender-affirming hormone therapy. And here are just the graphs where you can visualize this. The dotted blue are the transgender women. So you can see here that they had higher HIV DNA levels and that there was this sharper decline where it crosses the controls of TL2R. And while I understand that the significance of the long terminal repeat DNA, the 2-LTR DNA is debated and not entirely clear, we thought this finding was interesting and we decided to highlight it in our CROI abstract. Essentially, we thought it could potentially support our hypothesis that exogenous estradiol decreases HIV levels. However, we didn't find a difference in cellular HIV RNA between the transgender women and the cisgender controls.
Lizzy, there is a question about the time points
Yes.
that samples were collected post
Yes.
initiation. I don't know
Yes.
if you were going to talk about that.
Yes, just so we collected at time 0, and my understanding is this data includes time 0, as you can see on the graph. And then the goal was to do 2, 4, 6. Let's see, I have it here. 2, 4, 6, and 12, and 18. Though I don't have this data, and this is something that we'll definitely be looking at further in the future, is how many participants, how many samples over time were collected. So how many participants, provided just one sample versus multiple.
Lizzy, can I quickly jump in about the 2-LTR findings?
Yes, please.
Because it is a little bit, so like, it is an interesting finding and it is a little bit controversial in the field, the meaning of the 2-LTR. but many people believe that 2LTR generate when there is an aborted integration event. And so it has been used, especially in the past, as an indirect marker of ongoing application. I know that not everyone believes that's true, but we have been thinking in this, assuming this is true, the fact that this decreases faster in transgender women could be an indirect evidence that we are suppressing HIV replication. That's what I meant. And it is said we didn't see a difference in HIV transcription, which would have been a more direct way. But we have some plans to run some other virologic assay and see if we can confirm it better. So I just wanted to clarify, but because the 2LTR are a little bit of a tricky measure, but I still think it's interesting.
Thank you. Thank you so much,
I hope-
Sarah. Yeah, great. Okay, great. Thank you. So we also found some interesting results with the cytokine and chemokines. So here we have the cytokine partial least squares discriminant analysis projection, and the confident ellipses for the cases are in blue and in the controls are in orange. And we found that transgender women had a unique immune profile and that we could accurately predict the gender group with this model with a 10% error rate. That was very interesting. So like Sarah mentioned, we're still performing some additional analysis on this results and have some additional data to generate. So this isn't 100% finalized, but we are excited by these initial results. I think what's maybe equally as interesting is that in addition to this DNA, RNA levels and cytokine results, we thought that this study was an important demonstration of the unique challenges associated with recruiting and studying transgender women with HIV. So this is with regard to our retainment. So while we had 22 transgender women who enrolled, 9 were lost to follow-up. 1 was to suicide, 1 was to homicide, and 2 were from imprisonments. So I wanted to bring it back to the National HIV Behavioral Surveillance that I discussed earlier. So they mentioned that in their results that 18% of the participants of the over 1,600 individuals had SI at some point, and 7 had a plan for suicide, and 4% had attempted suicide in the past. And this is consistent with the 2015 transgender survey, where 40% of transgender people attempted suicide in their lifetime. Just to clarify, I don't know, the paper didn't mention the exact timing of these percentages, but they just listed as 18% of persons had SI. So I don't know if that's active SI or in the past. And they also noted that gender affirmation significantly decreases odds of SI. They also had some reports on abuse and harassment, and they had reported that because of their gender identity or presentation, 54% experienced verbal abuse or harassment, 27 had experienced physical abuse or harassment, and 15% from a sexual partner. They also found that 17% of transgender women did not have health insurance, 63% had a household income below the federal poverty line, 42% did not have housing in the 12 months before interview at some point, and 17% had been incarcerated. So with these findings, you know, we really, again, thought that this study demonstrated the unique challenges associated with recruiting and studying transgender women with HIV. And we feel that there's a need for improved trauma-informed care and tailored research efforts for this patient population. So as we've discussed some of the limitations of this study, so it's a limited sample size, you know, it's 22 with quite a few individuals who dropped out. There's variability in hormone regimen. So this is something we're going to work on, but, you know, they come in different forms and taken at different times, et cetera. And so there are fluctuations in hormone levels throughout the day. There's also presence and interactions of other hormones that, you know, aren't always taken into account, like testosterone, recruitment and retainment, as I already mentioned, And then again, the results are not complete yet, and the analysis is still being performed. So expect some updates in the future. So in conclusion, transgender women had a faster decline in 2-LTR after starting gender-affirming hormone therapy compared to the cisgender controls. Transgender women had a unique immune signatures based on that graph that I showed you. And there was a high percentage of loss to follow-up. So really the biggest conclusion, which I feel like we always come to, is that there is more research to be done. So we're excited to do that. So with that, I want to thank everybody, especially all the co-authors, but especially Sarah, Jill, Antoine, and Alan, who really helped me on the tail end of this project. And here are some of my resources. And I'm happy to help field questions as well, potentially with the help from Jill and Sarah, if there's anything that I can't answer. So thank you all so much.
Thanks, Lizzy. This is really nice. And can you remind us for Croy, is it a poster, it's a poster? Okay.
Poster.
So hopefully this will be, hopefully some questions that get asked will help inform that. There were, I know Sarah just came on and I see that she's in the car here. Let me see. Okay. So Nettie asked, thanks Nettie for all the questions. I think you can now see what she was asking. First,
I can just unmute, sorry.
I was just gonna say, I hope I answered. The trend survey was done in 2022. I know we were promoting at our clinic. So what I just found on the website is that those results should be coming in 2024. So we will have some updated findings, which would be really nice to see where we've come since 2015. But yeah, Nettie, if you now want to ask your question, please do so. Or sorry, there you go.
Okay, sorry, I was getting my mic set up. Can you hear me okay?
Yes.
So thank you for that. And really appreciate seeing more research in this area in this population. So I thought there were a lot of interesting questions coming out of that, and sort of what might be like an aside, but when you talked about all of the psychosocial barriers to retention and care and to your study, just got me thinking about, what I feel like more recently we're trying to pair direct benefit to the client in real time with our research projects that maybe answer questions for the future. So I was wondering for the participants, what the experience was with the study team of people coming in with acute needs, acute psychosocial needs, depression, hunger, et cetera, and then what the capacity was of the research team to manage that. And that might be something we could think about in future studies with this population or any population, sort of pairing that study contact with connecting to other services.
Yeah, that's a really great question. And I feel like, especially with this population, it would be important to include that with all studies. I unfortunately wasn't involved in the beginning part. I don't know if Jill, if you can comment on it at all.
Yeah, I think this was a long time ago, right? This was this 2016 when we started?
Yeah, 2016 is when we started.
Yeah, and I think
and Martin was the one. Yeah.
Yeah, I guess I can answer that question. So I was the clinical research coordinator for the study. And although we did not provide what we would call extensive case management, I think we all understood that this population didn't have a lot of unmet needs. I can say from what I recall, a good portion were experiencing homelessness at different times. Of course, food, nutrition needs. So, what's great is I think we know that there's a lot of resources in the community. So I know I try to do my best to connect them to those services since we don't offer them here, or I should say at the AVRC, even though we could not do full case management. And then, I think a lot of things too is since there were so many competing priorities, making sure that we did our best to try to engage them as much as possible through different means of communication. Some people never pick up the phone, but then would only text. Some would only email. So it's just a variety of things. But yeah, I definitely recall making sure that we connected to people like townspeople or other services that tried to find housing, Mama's Kitchen, all those kind of things.
Yeah. Marvin, you're
But
amazing.
am I right, Sarah? Almost all of the referrals were patients from Owen, who
Yeah,
therefore were ostensibly connected and had case managers. I think the study gave them additional opportunities to, and I think these were people who had probably never participated in research before, maybe a little bit, but sort of having that experience. And, Marvin obviously is one of a kind. So I think that was good, but fortunately or unfortunately, these were patients that were in care, so they did have access to, what the offerings were at Owen, which in 2016 were slim. I think we had one social. Sorry, I'm only laughing because it's sad and it's exciting to see where we've come from since then.
But
Well,
Jill, if I can say, if I can say something about this study, is that we had very little resources at that time. It was one of the first study that we tried to design, including transgender women. I didn't even know Jill at the time, and now we are kind of best friends. And I think that because we connected and we did realize all of the challenge, from here, the TCAP started. We wrote the review about in CID about how to better engage transgender women in HIV research. And some of you might be familiar, the ACTG study 5403 just hit the field, which is basically a better version of this study. And I started that study. Now I'm not the chair because then it came a long way. But, when we realized this, we started the conversation with the ACTG, and now it's 5 years later, we have a randomized trial of gender affirming care, and it's the first ever ACTG study to enroll only transgender women. So I think while this particular study was underfunded, it really triggered a chain of events. And I'm just so excited to see it published 5 years later. So I'm so happy Lizzy took it over and is bringing it over the finish line.
Thank you all. Any other questions?
Lizzy, do you want to talk a little bit more about because obviously these are very preliminary results, and I know that, we generated, we increased a little bit the sample size, we are reanalyzing the data, we have the flow cytometry results coming, so just, we will have a more complete story, hopefully by soon.
Yeah, one thing that I've been doing is going back through the Houston participants and adding in some additional information about their adherence to ART and regimen. So we'll have some more information about which hormone therapy regimen they were on and ART regimen, and as well as the timeline. So we'll be able to provide some more information about how many samples over time, and potentially include some sort of time component to these results, knowing that, hormones therapy that's going to fluctuate, potentially reach a steady state overall over time. So we'll have a lot more to reflect on in the future, which will be great.
That was great, Lizzy. Great job.
Thank you all.
And I think we all love a concise presentation that gives us a little time back in our lives. This is a good lesson for everyone. We don't have to talk until the end of the hour. A lesson for me as well, I will admit. So Lizzy, thank you so much. And I think we look forward to lots of interesting presentations from you in the future. And I know that you've done some work and again, carrying some things forward related to, the effect of PrEP on different, I don't want to say reservoirs, because obviously there are no reservoirs, but on various biological factors, and maybe we'll hear about that in the future. But thank you so much, Lizzy. And I don't know if anyone has any last questions. I think I think no. Lots of applause for you. And I hope that we'll see everyone next week, not in person, but I did want to put a plug in for next week because we'll be hearing about some of the updated guidelines for breast chest feeding in individuals living with HIV who've given birth by a couple of our Demo and colleagues, Karen Deutsch and Kelsey Nuno. So it should be really, really cool. And anyway, we will see you next week. Thanks everyone for being here. Have a great Friday and weekend.
Thank you.
Thanks, Lizzy.